So I'll be taking you through preeclampsia and placenta pathologies. My name is Zanga. I'm a specialist fetal sonographer. Just to preach to the converted, I'll just recap what preeclampsia is, which is de novo gestational hypertension after 20 weeks of gestation, which is accompanied by proteinuria, as well as they can be, or sometimes they can't, they will not be maternal liver or kidney or hematological disease. So preeclampsia is a major contributor to the maternal and neonatal mortality and morbidity globally. It is the second largest cause of maternal mortality worldwide and affects 5 to 7% of pregnant women globally. As you are aware, preeclampsia is divided into early onset and late onset, with the discriminator being 34 weeks. So it occurs before 34 weeks, it's referred as early onset. If it occurs after 34 weeks, then it's referred to as late onset. So in early onset preeclampsia, it has some typical features, which include, I'll also touch this in the next slides in a bit greater detail. There will be inadequate and incomplete trophoblast invasion of the maternal spiral arteries. And there will be changes of the blood flow within the placental bed spiral arteries, and this can be depicted through high uterine artery PI. So there will be high resistance within the uterine arteries. They become sort of stiff, and the flow can be with or without notching. There will also be an increased peripheral resistance of placental vessels. So they will be depicted through high umbilical artery PI, which will have decreased antidiastolic flow. It can be absent, and in most cases, there will be reversed flow during diastole. And there will be kind of fetal growth restriction. Then the side, we've got late onset preeclampsia, which contributes over 4/5 of all preeclampsia cases globally. And some of the typical features include they can be a normally growing baby with no signs of any growth restriction. A normal or slightly altered behavior can be exhibited in the uterine spiral arteries, and these can be seen by there being some slight changes in the uterine artery PI, a slight increase in the resistance, or there can be no change. Then there will also be no changes in the blood flow of the umbilical arteries. So they will be having normal PI values. And there'll be a risk for enlarged placental mass. I think this was touched on earlier on. In cases of diabetes, multiple pregnancies, anemia, and high altitude. The pathophysiology of preeclampsia. The events can be grouped into adaptation of immune response to pregnancy, which those bacterial effects and findings, which include inadequate extravenous trophoblast migration, chronic chronic chorioamnitis. Then there can also be inadequate extravenous migration, manifesting as unconverted placental bed spiral arteries, increased multinucleate trophoblast cells in the basal plate. And one of the key pathophysiological event is intrauterine hypoxia, which will manifest through persistent villus trophoblast, presence of fetal nucleated red blood cells in villus vessels, choriocysts. It was touched on earlier on. So I'll just take you through the normal versus the preeclamptic pregnant woman. So in the normal, the maternal spiral arteries will appear normal, whilst in the preeclamptic pregnant woman, there will be abnormal spiral arteries remodeling. Then there will be normal cytotrophoblast invasion in the normal pregnant mother, whilst in the preeclamptic pregnant woman, there will be reduced cytotrophoblast invasion and proliferation. Then there will be normal oxygenation in the normal pregnant mother, but in the preeclamptic pregnant woman, there will be placental hypoxia. No resistance to blood flow in the normal versus placental ischemia and increased oxidative stress in the preeclamptic pregnant woman. Then there will be increased blood flow in the normal versus decreased blood flow in the preeclamptic mother. So what will be the consequences? In the normal pregnant woman, there will be normal angiogenesis because there will be more of the placental growth factor in comparison to the soluble globulin as well as the S-FLT1. Whilst there is, you can see on the scale there that in preeclamptic pregnant women, there's a tipping of those hormones, the soluble endoglin as well as the S-FLT1, they increase. And these ones are anti-angiogenic factor hormones, and there'll be a decrease in the placental growth factors. This is further depicted in the next diagram, as you can see here. So in the non-pregnancy, you can see that the nutrients, the pressure, the oxygen, they are normal, and the pro-angiogenic factors, which include the vascular endothelial growth factor, the placental growth factor, as well as the angiopoietins are all normal. And you can see that the anti-angiogenic factors, the S-FLT and the soluble endoglin, they are decreased. And this will result in normal vessel formation, as well as normal fetal growth. However, when we've got an increase in the S-FLT and soluble endoglin, there is increase in the antioxidants as well as the oxidative stress, which can result in abnormal vessel formation and resulting in reduced growth. Then you can see on the last part that there is now inflammation, apoptosis, necrosis, and the rate of oxidative stress is also increasing, resulting in abnormal vessel formation as well as reduced fetal growth. This next diagram is just showing us the normal versus the ischemic representation of what will be happening. You can see here during our remodeling, the remodeled artery, you can see it's wider, and you can see the villi, they are more, and you can see by the presentation of the villus trophoblast, the Hofbauer cell, and the villus endothelium. Whilst on the ischemic one, there is now syncytial knotting as well as fibrin deposition, and it results in stiffness of these vessels, and it will have an impact on the flow of blood through the placenta. I think some of these ultrasound images have already been discussed earlier on. The first one is just showing ischemia. You can see the ischemia there. Then this one is a hematoma. And this one are some calcifications, which will inform our next table, which I'll be discussing a study which was done by Zanga et al. In Nigeria. It's a study which was conducted here in Africa, whereby they were looking at placental peripartum pathologies in women with preeclampsia and eclampsia. And it constituted 61 cases. And of the 61 cases, 53 of them had preeclampsia, and 8 of them had eclampsia. And the control group are comprised of 122 normal pregnancies. So in this study, this is a snippet of some of the results. So you can see as far as infarction, if it was between 0 to 5%, according to the p-values at the end there, they were all statistically significant for the mild preeclampsia, the severe preeclampsia, as well as the eclampsia. Okay, I'm hearing my screen is not coming. Let me just sort out that. All right, so I'll continue. I hope you're seeing the screen, which is showing us the results of the Zanga et al. Study conducted in Nigeria. Where I said they had 61 cases, as well as 122 controls. And the 61 cases were 53 women which had preeclampsia, and 8 which had eclampsia, and 22 controls. So I was now elaborating on the result of the infarction, which if they were between 0 and 5%, they were statistically significant for the mild, severe, as well as the eclampsia, with p-values of 0.02, less than 0.001 for the severe preeclampsia as well as the eclampsia. Then, if you look at the second highlighted row of 11 to 20% infarction, there was no statistical significance in the mild preeclampsia, but it was exhibited in the severe preeclampsia as well as the eclampsia. Then if they're greater than 20% infarcts, they were not statistically significant again for the mild, but they were statistically significant for the severe preeclampsia as well as the eclampsia, with p-values of 0.001 and less than 0.001 respectively. Then when they looked at hematoma, if the hematoma was absent in the 3 groups, the statistical significance was there for all three with respective values of 0.009, less than 0.001, and less than 0.001 for the severe and eclamptic groups. Then if it was present with 2 pluses, it was statistically significant for the severe preeclampsia and the eclampsia group, but no statistical significance on the mild preeclampsia. Then finally, if you look at the calcifications, if they were absent or if they were just 1 plus, there was no statistical significance. But if there were 2 pluses, they were statistically significant for the mild preeclampsia with a p-value of 0.001. No statistical significance for the severe, and also no statistical significance for the eclamptic group. So these are the gross placental changes. Now I move on to the histological findings. So as far as the histological findings, we've got stromal edema. I think some of these were talked in detail earlier on by the pathologist. We've got stromal edema, stromal fibrosis, syncytial nodes, heterotropoblastic proliferation, accelerated villus macula, as well as decidual arteriopathy. So in the 3 groups, you can see the p-values at the on the column at the right, on the right side, and you can see the ones which are underlined are the ones which were statistically significant. So for cytotrophoblast proliferation, it was statistically significant for the 28, contributing 71.8% with a p-value of 0.001, as well as for the eclamptic group, 6 contributing 0.001. Then for the accelerated villus maturation, it was statistically significant again for the preeclamptic and the eclamptic groups with p-values of 0.01. Then for decidual arteriopathy, it was statistically significant, the manifestation in the eclamptic as well as the severe preeclamptic groups with respective p-values of 0.01. So what's the take-home message? We are trying locally to come up with sort of our own sample locally, whereby in the private sector, the process has started of sending some of the placentas that would have been flagged to have some placental lesions during ultrasound scan evaluation in these preeclamptic mothers, and they are being sent to the laboratory. It's still in the early stages, but I think with the process of time, we believe we're going to have a very good sample of these placentas to also have the data analyzed to see if there are any variances, probably with the Nigerian study or any other studies. However, there is need for collaboration between the obstetricians and the pathologists in studying more placentas with lesions. I think the pathologist earlier on highlighted that it doesn't cost much, but it might be worthwhile sending these placentas for further scrutiny. However, there's need for a consensus on the critical aspects that want to be included in the histological report so that the different cases won't have the same histological report outcome. Thank you. That concludes my presentation. I would like to acknowledge the Fetal Medicine Foundation Zimbabwe, the Fetal Medicine Units team, teams at Salem Gabe and Parinyatwa, as well as the Fetal Clinic. And those are my references. So that concludes my talk.